So here we are at the knee, a complex, totally functional, incredibly necessary joint in our body that is essential. I mean, this joint is really cool, and unfortunately, I like to kind of call it our poor little stepchild, because dysfunctions above and dysfunctions below will tend to manifest in pain in the knee joint, and we'll see mild and chronic problems in the knee joint coupled with significant traumatic injuries in the knee joint. And those traumatic injuries can occur from direct contact, or they can occur from indirect forces that load through the knee, and the supporting structures just aren't capable of withstanding those loads. But it's a complex joint, and it consists of two articulations located within a single joint cavity, or a single joint capsule. The primary role is to support the body during dynamic and static activities, and it's the direct link between the hip and the ankle. So it shortens the moment arm when we walk. It provides stability when our foot hits the ground, and we project ourselves forward over the top of our foot while we're walking. So it's an incredibly cool joint, and we're going to get into how it functions and the critical structures that make up this joint, and see how the muscles that cross the joint impact it in multiple directions. So when I start looking at the structure of the tibiofemoral joint, it's considered to be a double condyloid joint with 2 degrees of freedom. When I say double condyloid, that's a function of the medial and the lateral condyles of the femur. And when I'm talking about 2 degrees of freedom, we have motion that occurs in extension and flexion, which would be sagittal plane motion along a frontal plane axis. You can see that tibia want to slide back over those femoral condyles. We also have a rotation component that sometimes people don't recognize in the knee, and that's a transverse plane motion of the tibia. So the transverse plane motion of the tibia occurs with this small amount of tibial rotation, and we're going to talk extensively about the screw home mechanism, which occurs at terminal extension and about the last 20 degrees of extension as the tibia externally rotates. But we actually have active external and internal tibial rotation, which again occurs in the transverse plane, and it occurs about a vertical axis. And we can actively internally and externally rotate. And in my animation here, we're looking at the long head and the short head of the biceps femoris tendon attaching to the fibular head, creating an external tibial rotation. So the large medial and lateral condyles on the distal end of the femur form the proximal articulating surface. So they are convex anterior-posterior, but they are not perfectly spherical. Similar, the head of the femur fits in that nice acetabulum. It's a little bit more spherical. These are much more oblique in nature, not nearly as round. And then they form again the double condyloid. So there's essentially two individual condyloid joints within the knee. They're separated by this intercondylar notch that runs almost up to the patellar surface, a patellar articulating surface, where the patellar groove joins the condyles. So this articulating surface here is the patellar articulating surface. And it's separated by the tibial articulating surface by two slight grooves that run obliquely across the femoral condyles. And that separates the tibial articulating surface with the patellofemoral articulating surface. The shaft itself is not vertical. It's oriented laterally, and as such, a majority of the load comes through the joint over the lateral, more in line with the lateral condyle. So when I look at the articulating surfaces, we can see that they're not congruent, they're not the same. The lateral articulating surface tends to be more in a, if I can align this a little better, the lateral articulating surface tends to be more vertical in nature. It's oriented more along the sagittal plane, where the medial articulating surface tends to be oriented in a little bit more of an oblique plane. Now, the articulating surface of the medial side is also longer. It's about 2/3 of an inch longer on average. So this allows the medial femoral condyle to extend with greater length, and we'll see as we talk about that rotation component that we saw earlier, how the medial orientation of the condyle impacts directly that medial and lateral rotation of the tibia during flexion and extension. So the distal articulating surface is the tibial plateau or the tibial condyles, and they are two asymmetric condyles. Medial surface is about 50% larger than the lateral surface. So if I bring this around, we can see a much larger surface on the medial side than I see on the lateral side. And they're separated by the intercondylar tubercles, which is the attachment for the cruciate ligaments. And we'll visit those ligaments in a minute. Because of the incongruence in how that femur needs to sit on the tibial plateaus, we have corresponding fibrocartilaginous menisci, which enhance the relationship for both the mobility and stability of the joint. The medial meniscus is more of a semicircle. The lateral is almost a 4/5 of a ring. So this is almost a complete circle. This is more of a semicircle. They both open toward the intercondylar notch, or the intercondylar tubercles, and they're thicker on their periphery. So you can see how they want to lip up on the periphery. They're attached to the condyles by coronary ligaments along the periphery. And there's a direct or an indirect attachment to the patella via the patellomeniscal ligaments, which is really just an anterior thickening, as well as the anterior horns are attached via the transverse ligaments. So the ligament across the anterior side attaches the anterior horns via the transverse ligament. And posteriorly, a portion of the lateral meniscus runs with the posterior cruciate ligament via the posterior meniscal femoral ligament, and will occasionally have attachments to the anterior cruciate ligament. And medially, the medial meniscus joins with the MCL. So the deeper fibers of the MCL join the lateral border of the medial meniscus. Let's take a minute and talk about the joint capsule. Stability is really dependent on the surrounding structures in the joint. And so during knee flexion, which is the loose pack position of the joint, the static stabilizing structures are most lax. So we have quite a bit more accessory anterior-posterior glides and tibial rotations, much easier to assess in about 20 or 30 degrees of knee flexion. The capsule itself is a very large and complex structure with a lot of attachments. Posteriorly, the capsule is attached to the femoral condyles and the femoral notch. So here is the femoral attachment of the articular capsule, and it runs inferiorly down through the intercondylar notch and attaches to the posterior tibial condyles. It is reinforced by the posteriorly by the oblique popliteal ligament and the arcuate ligaments. Sometimes we'll hear that called the arcuate complex. Medial and laterally, the capsule begins proximally above the femoral condyles and inserts into the margins of the tibial condyles. So it comes all the way down and attaches along the tibial condyles. Anteriorly, we can see the patellar tendon and the patellar ligament coming down, and that reinforces the capsule from anteriorly. And there's also a thickening of the capsule, both anterior lateral and anterior medial. And we like to, well, that's what we typically call that thickening is the extensor retinaculum. Now, when we talked earlier on in the term, we talked about what makes up a diarthrodial joint, the joint capsule being one, and the synovial lining and synovial fluid being another one of the components. So the synovial lining in the knee joint is the most extensive and involved in the body, and it lines the inner wall of the capsule throughout the whole capsule except posteriorly. And posteriorly it follows the condyles into the intercondylar notch. So that results in the structures of the ACL and the PCL, which we'll get to here in a minute, become intracapsular. So they're inside the capsule, but they're extrasynovial. And if the synovial fluid is what provides nutrients to structures, with the ACL and PCL being extrasynovial, their opportunity for blood supply and nutrition is fairly limited. Now, the synovial lining embryologically is formed by the joining of three separate compartments. And when the synovial septa or the seam are present in the adult knee, they are called the synovial plica. And typically the plica go on through life and tend to be nice loose structures that are compliant, they're elastic fibrous tissue, and they easily pass between the patella and the femoral condyle, especially while the knee is flexing and extending. But if they become inflamed or irritated, they can swell just like any other tissue, and when they swell, they become problematic. So we start to see a clicking. We may have a clicking sensation, and oftentimes in the medial patellar plica, we can end up with symptoms very similar to medial meniscus tears. So the plica is again a structure that is palpable. You can palpate it medially and it feels just like a seam, like you'd feel the seam in your shirt. And normally it's not tender to the touch, and it's nice and elastic, and it's just a remnant of development. But in some cases it can become irritable, in which cases squats and stairs will tend to be irritating. Anything that takes the knee into a loaded position of flexion. We'll take a few minutes and talk about knee ligaments. And remember, ligaments are designed to control or resist motions that were not that are not functional. So primarily, the ligaments of the knee designed to control excessive knee extension, resist against valgus and varus stresses, anterior and posterior tibial displacement against the femur, and tibial rotation. Now the reality is they all kind of work to resist any or all combination of those motions. So let's start with the medial collateral ligament. And the medial collateral ligament attaches to the superior aspect of the medial condyle, and it runs anterior and inferior to the medial aspect of the proximal tibia. The posterior fibers blend with the joint capsule, and some of the fibers attach to the medial meniscus, as we talked about before. And the ligament checks excessive valgus in the knee. And it also, again, because of this oblique orientation, also checks lateral rotation of the tibia. Turn the knee around to the lateral side, we can visualize the lateral collateral ligament. Now, the lateral collateral ligament is extracapsular, and it's smaller, but it's a nice, strong, cord-like structure, and it functions to check excessive varus loads or varus forces. And it runs from the lateral femoral condyle to the head of the fibula. Now, we always hear about the anterior cruciate ligament in the knee, and the anterior cruciate ligament that gets torn or gets ruptured. And so I'm going to take away the patella and the patellar ligament, and we can kind of get an anterior view of the anterior cruciate ligament. And if I spin this down, we can see that the anterior cruciate ligament attaches to the anterior tibia and attaches under the transverse ligament. So remember, we talked about that transverse ligament attaching the two anterior horns of the meniscus. Runs posterior and superior to attach on the inner aspect of the lateral aspect of the femoral condyle. So it runs diagonally up to attach to the inner aspect of the lateral femoral condyle. There are, in fact, two fiber bundles, and they're named based on their attachment to the tibia. There is an anterior medial band, the AMB, which becomes moderately lax in extension but tightens in flexion, and actually becomes the most tight maximally at about 70 degrees of flexion. There is also a posterior lateral band, or the PLB, which is tight in full extension. So you'll hear sometimes about surgical repairs of the ACL, and they will take a patellar tendon graft, for example, and replace the ACL. And one of the theories is because the anterior medial band is responsible for A to P translation, and the posterior band is more rotary, more of a rotary stabilizer. That if you just use that single band replacement, that you're going to be missing some of the rotary stability. So what some surgeons do is they'll try to adjust where they attach where they attach the graft on that border. And some surgeons are starting to use what is called a double bundle technique, where they're taking a tendon from the semitendinosus so that they can have actually have two separate attachments and attempt to reproduce a more native footprint for the ACL. Outcome studies are good on both, and I've treated hundreds of patellar tendon graft ACLs, and they do great. Now the ACL checks again that anterior translation against the tibia on the femur, and it twists around. You can see here at its distal attachment, and it winds around, this being the posterior cruciate ligament, winds around the posterior cruciate. And that's what helps to check the lateral tibial rotation. And it carries about 87% of the load in anterior tibial translation. Now the posterior cruciate ligament runs superior from the posterior tibial origin along the tibial condyle to attach to the inner aspect of the medial femoral condyle. Now it's much shorter, it's much thicker, and it runs in a much less oblique orientation than the ACL. And the two fiber branches are named based on their attachment to the tibia as well. So there is also an anterior medial branch, which is lax in extension and tight in about 80 to 90 degrees of flexion. And there's a posterior lateral band, which is lax in flexion and tight in extension. Now the PCL checks posterior translation of the tibia. So if the tibia wants to slide posterior against the femur, it's going to be checked by that PCL, and it carries about 93% of the load in posterior translation of the tibia. Tension in the PCL may be is vital in lateral rotation of the tibia during terminal rotation. So as we look at that terminal rotation, terminal extension, the tibia rotates, the PCL is going to be very important in providing a pivot point for the tibia to rotate. So the posterior capsular ligaments are posterior medial capsules reinforced by the oblique popliteal ligament, which is a tendinous expansion of the semimembranosus muscle or tendon. Passes from the posterior medial tibial to the central part of the posterior capsule. The posterior lateral capsule is reinforced by the arcuate ligament. The arcuate ligaments here. Rises from the posterior head of the fibula, passes over the popliteus muscle, and attaches to the intercondylar area of the tibia and the lateral epicondyle of the femur. They are taut in full extension, and they assist in checking hyperextension. And the arcuate plays a role in checking varus motion. So it's a secondary stabilizer in varus motion. And we look at the oblique nature of that ligament, and we can surmise that it also has a function in stability during tibial rotation. Now the oblique popliteal also plays a role in checking valgus motion, and again looking at the oblique orientation, we can surmise that it has a role in rotational control. So sometimes we will see a ligamentous injury to the lateral corner, posterior lateral corner, and end up having to assess arcuate ligament stability, and which manifests as an instability during cutting motions and kind of that transverse plane stability. Okay, so we'll spend a minute coming up here and talk about how the knee joint functions.